of stay, assigning the critical care pathway. So what we have started doing in Janssen series, I developed critical care pathway. And I think following critical care pathway for pneumonia treatment seem to have done three things. It has reduced the length of stay, it has minimized the unnecessary use of antibiotic, and perhaps we identify the complication very early on. So not wait till patient is crashing on the floor. Now, impact of community-acquired pneumonia hospitalization on long-term outcomes. This is a retrospective study, again showing that patient hospitalized with pneumonia compared to patient hospitalized for conditions other than pneumonia, and that will change the length of stay. Significantly shorter survival among community-acquired pneumonia plus patients other than community-acquired pneumonia. If you identify this very early on, and you will have to make novel adjustments for pre-existing comorbidities through a comorbidity index based on clinical data and age. Remember, when you put a diagnosis or DRG or particular CPT code, not only it is a good practice of medicine, it affects the reimbursement. So if you are specific about bacterial pneumonia or pneumonia with certain complication, then insurance company, the hospital analysis of quality assurance or assessment will look at it differently. So you have to be more specific when you dictate your discharge summary in what kind of pneumonia you're talking about. Not just say right low level pneumonia. Be specific. I'm going to pass this lower respiratory infection for the sake of time because I want to allow some time for questions and answers. But lower respiratory infection sometimes is mistaken as a pneumonia. Patient with bronchiectasis particularly may have Mycobacterium avium. I have seen aspergillus go from them. It's a complicated issue, but it is different than community-acquired pneumonia. So I'm going to skip that topic. But here's the bottom line. Before I end, this is a summary. Staph pneumonia is the most important pathogen in etiology of community-acquired pneumonia. Several tools help identify patients that require hospital or ICU admissions. Biomarkers can help decide the need and duration of antibiotic therapy. Bacterial resistance is prevalent, and local rates of resistance should be considered when selecting antimicrobial therapy. Use of guidelines improve outcomes. That has been shown by several papers, and it probably will appear in your board exam. There are improved process of care that can shorten length of stay in the hospital. The diagnosis of community-acquired pneumonia affects long-term outcome. So I'm going to stop here because I would encourage you to ask questions. I would also invite some comment from Dr. Mormon or Dr. Jim Meyer if he's in the audience, because community-acquired pneumonia is a very, very important topic, not only in your day-to-day practice of medicine, for your own family members and yourself, and of course for the board examination. I do not have time to discuss pneumonia vaccine and the newer vaccine, but that's a separate topic by itself. So thank you for staying awake and thank you for your attention. Ask any question if you want to. Yes, ma'am.
But I still ordered atypical screen. Is this norm to do it, or is we not doing it right?
Well, first of all, this idea that atypical pneumonia always involves multiple lobe is not true. I mean, yes, frequently you will see atypical bacterial infection causing more than one segment or one lobe, but that is not always true. I mean, you could have only one lobe involved and it could be a typical bacterial infection. It really depends upon your clinical suspicion. In one of the handouts I have given, if you have more muscle aches, previous flu-like syndromes, then yes, I would do more screening for atypical, like urinary antigen for Legionella, for example. But if it is a acute illness without previous viral infection, probably not necessary.
couple of comments. You presented a case of lung abscess, and the correct answer was ampicillin, sulbactam, whoever said that. But the incorrect answer on your boards would be metronidazole. We think that metronidazole is so good for anaerobic which it is, but for the clinical entity of lung abscess, it is not.
Right.
It's a more complicated process than metronidazole. It's an absolute wrong answer. They will not get better. You can use ampicillin, sulbactam,
Yeah.
you can use clindamycin even, and their treatment is for a very prolonged duration.
Thank you. Thank
I
you.
think we are going to have to at some point discuss the vaccine.
Yeah, that has to be a separate topic. I was going to cover, but I thought that would push me for the time, and I did not include that.
We will discuss that because I think that's something we probably have to implement in clinic and have some discussion about how we're going to do that.
Now, the pulmonary fellows are taking pulmonary board or busy with them, but typical pulmonary question is, if you have a lung abscess, do not try to rush for surgery because newer antibiotics and a good antibiotic choice can usually treat most of the lung abscesses without drainage. See, when I was doing my fellowship many, many years ago, we used to consider chest tube drainage. I don't do that anymore. In the last 20 years, I have not done a single lung abscess surgical intervention. So please remember that our anaerobic coverage and antibiotics are very good for most of the lung abscesses. There are some exceptions, but by and large, antibiotics should take care of it. Yes, sir?
Patients with MRSA pneumonia, once you treat them, sometime after 3-4 months, you still see MRSA in their sputum, but they don't have any symptoms. What should we do with those patients?
They would just need the treatment for the colonization and not for the entire pneumonia.
I'm not talking about nasal colonization. Sometimes we even see in the sputum, you know.
Well, I will wait for Dr. Jonathan Mormon, but I do not, I just provide good hygiene and not necessarily retreat the entire MRSA pneumonia vancomycin course. If patient is clinically stable, chest X-ray is improving, white cell count is going down. But I'll see what Dr. Mormon
Part
says.
of the difficulty with isolation of Staph aureus is that it's commonly colonized. So sometimes we call things that are community acquired or
Colonization, yeah.
pneumonias with Staph aureus in their environment, sort of driven by Staph aureus. People are colonized, so it's really hard to tease it out. If they're not having any clinical symptoms, I definitely don't treat it. It's very, very hard to decolonize somebody. I try it all the time. I fail most of the time. People, once it gets into the mucous membranes, it's everywhere. It's in the axilla, it's in the groin, it's in moist areas. It's almost impossible for us to get rid of it. If they have any kind of hardware in, peg tubes, plastic, they're not going to get rid of it. And I don't even try. It's not worth it. It doesn't work. If they're clinically ill,
That's a different story. I mean, I have few patients with bronchiectasis that I frequently use antibiotic, but they're going to have some staph in their upper airway, and nothing I can do. I mean, sometimes they even ask me to do bronchoscopy and wash it out. I don't know that will help. I don't do it. Yes, sir.
You mentioned that there's a rising prevalence of MSRA and community-acquired pneumonia. So my question, I guess, is, do you see any role of, typically when you admit somebody, you always add azithromycin for atypicals, but it would seem like there'd be a role for maybe perhaps an doxycycline in lieu of, but do you think there's any role for that, or should you just stick with it?
That's a very good question. I have seen at least my partner using doxycycline more frequently than I do. And there is some role for doxycycline. Most of the patients have some GI upset from doxycycline. So that's the reason I don't use it. But again, doxycycline is not the best drug for MRSA, as you know. So if you really have a commitment to the belief that MRSA is the cause of pneumonia, then you better go for vancomycin.
I guess in those cases to where it's not clear-cut, meaning...
Yeah, I would go for doxycycline. At least I have done it before. Is that the answer?
Yeah, I had this discussion with Dr. Myers yesterday. Because of the whole QT problem with the macrolides, in particular things like azithromycin, should we just be replacing it with doxy? Is not bad for Staph aureus, right? MRSA.
Yeah.
Soft tissue, we definitely get some of the lungs. We've used it for atypical pneumonias, and we kind of feel like they should perhaps consider changing those guidelines. They have doxy.
Yeah, I've been using doxy a lot. And at least you don't have to worry about the QT interval as much as it is. Yeah. Yeah.
People have been going more towards that. It's a very odd drug, doxycycline, very multifunctional. We always say if you're on a desert island and you could only have one drug,
I would like to have doxycycline, yeah.
Just look at the indications. It's ridiculous. Everything from STDs to malaria to anthrax to...
The last question, then we'll stop because it's almost 9 o'clock. Yes, Dr. Pincha.
So doxycycline, my understanding is it covers only community-acquired MRSA, doesn't cover the hospital-acquired MRSA.
That's not how it works. No, so hospital-acquired MRSA and community-acquired MRSA were very clear up front.
Two
a few
different
years
things.
of this, but now they're kind of all blended together, and it really comes down to just sensitivity. So we'll have to look and see how sensitive or the tetracyclines or anything, even trimethyl sulfides. We don't know. They're all kind of blending together now. Originally, it was very easy to see this as a hospital-acquired MRSA because of its resistance pattern, and community-acquired was really inconsistent. Now they're all kind of blended together. You have to go by your sensitivity.
Thank you very much.